It gives me great pleasure to be talking at the 8th Emirates Pathology and Digital Pathology Conference. I'm just going to put it into there we are. My topic is the enigmatic Spitz nevus, and Spitz nevi have always seemed to have been a problem ever since Sophie Spitz described them in 1948. And one of the things I've noticed over the years in the literature is almost all papers start with this statement: Spitz lesions are a source of great diagnostic difficulty, which to me is an almost self-fulfilling prophecy. It means that a less experienced dermatopathologist, when faced with a spitzoid lesion, will automatically think, oh gosh, this is going to be difficult. And of course, that's not true. 95% of Spitz nevi are recognized at scanning, magnification. And I just put this little picture in to show you the most perfect Camino bodies. Now, I've subtitled my talk The Good, the Bad, and the Ugly, and that refers to the malignant variants, and I'll come back to them later. I just want to acknowledge that this presentation wouldn't have been possible had it not been for the help of so many friends. And I just want to give you my financial disclosure of royalties from Elsevier and Walters Kluwer. Now, this slide, I think, helps to encapsulate the problems we face with Spitz lesions. The first point we need to remember is that the term Spitz tumor includes a variety of different entities, including Spitz nevus, atypical Spitz nevus, Spitz melanoma, and spitzoid melanoma, and I'll come back to those later as we progress. And one of the things that I've learned over the years, I used to believe firmly that morphology was the be-all and end-all, but when it comes to Spitz nevi, when you make a diagnosis based purely on morphology, you can get into trouble, and I'll come back to that. And of course, the more experience you have, the better you will get, but even then, there can be problems. And lastly, the concept of the atypical Spitz nevus or the atypical Spitz tumor, this arose as a direct consequence on morphology-based diagnoses. I think one of the biggest problems in the Spitz nevus story is the atypical Spitz nevus. So one of the things that I had to change my mind about is the importance of immunohistochemistry. It really is very, very useful in any tumors where there's diagnostic difficulty. That's not to say that every Spitz nevus needs immunohistochemistry, but sometimes they do. And as I'm dealing with an international audience, if you don't have this available at a local level, I would suggest perhaps you could get a regional laboratory to sort this problem out. And the same thing applies to FISH, ACGH, and next generation sequencing. In the really difficult cases, you may well need these tests, and that can probably be set up on a regional basis, or sometimes even a consultation will do it for you free. One of the most interesting aspects of the Spitz nevus story is the fact that Spitz nevi may be associated with sentinel node positivity, and this may not mean anything very much. So the old idea that if a Spitz nevus spread to the local lymph node meant it was a melanoma with all the grave consequences of that, it is in fact not true. And lastly, even with the best of technologies, immunohistochemistry and other molecular techniques, the tumors don't always do what they're supposed to do. So homozygous deletion or loss of 9p21 can sometimes be associated with a good rather than a bad prognosis. So this is just to remind you again, Spitz tumor includes Spitz nevus, atypical Spitz nevus, and both Spitz melanoma and Spitzoid melanoma, and I'll come back to the difference between these two later. This is a bit of a reality check. It's just to remind you that Spitz nevi are very rare. In 1977, David Whedon did a study, and it showed there were 1.4 cases per 100,000 person years. And so that means that for an average dermatopathologist not working in a consultation practice, it's unlikely that he's going to see more than 4 or 5 a year. And of those 4 or 5, most years they're all going to be utterly benign and non-problematical. It's a disease it's a tumor, a lesion that we see mostly in children, but it in fact can present at many ages, going right up to the 50s and 60s, which is something that I never used to believe. And sometimes you get multiple lesions either grouped, or they can even be eruptive. And this perfect clinical, which is a typical Spitz nevus, was shared with me by Antonina Kalmykova. And histologically, Spitz nevi, they mostly can be recognized at scanning magnification, and this is a perfect example here. And you look down at this at low power, and you can see the lesion is circumscribed, you can see it's symmetrical, you can see its wedge-shaped morphology. And so when you start, and this is, say, from a young person, this is a Spitz nevus, unless you really prove beyond all reasonable doubt that it's a melanoma. So with children in particular, start off with the concept that the lesion is benign and only call it melanoma after you've fulfilled many criteria. And I've got this list on the left, which you can find in any textbook, and I'm not going to spend much time on it, other than to say none of these are absolutes. So communobodies may be present or they may not be present. Maturation with depth is generally present, but sometimes it's not so good. It's not so obvious. So it's the sum total of all of these features that make it a lesion of Spitz nevus rather than any one particular one. And this is a lovely case. It's actually an alcoma that Antonina shared with me, and it's showing perfect symmetry. It's also showing maturation with depth. If you fold the left over to the right, they match perfectly. The other way of looking at it is by drawing horizontal lines and comparing the size of the nests and the cells on the left with the right. And as you work down, you can see that there are mirror images. And this also is a good way of assessing maturation, where you can see smaller nests and single cells at the base. So when you look at that low power magnification of that particular lesion, you can say that's a Spitz nevus without looking at it any further. And here's another Spitz nevus, and this is an example of an epithelioid Spitz. And when we look at it a bit closer, you can see the epithelioid cells with large vesicular nuclei and prominent nucleoli. And there's a mitosis, which is a common feature, particularly in children. And that's the base of the lesion. If you compare the cell size at the top with the bottom, you can see this clear maturation. And in this field, it's heavy pigmented, because sometimes Spitz nevi are very pigmented. And this is an example of a spindle cell Spitz nevus, again shared by Antonina. And in this example, most of the nests are composed of spindle cells. And this example shows very nicely the retraction artifact and discohesive cell population that we expect to see in a Spitz nevus. And I put this one in. This is a reed nevus, and Ihar from Moscow kindly shared it with me. And I think this overlaps a lot with pigmented Spitz nevi, and I don't really distinguish them particularly. It doesn't really serve any great purpose. Now, as I mentioned, most Spitz nevi you can recognize on H&E, and you can be pretty confident about it, but sometimes you do have problems. And so we do have a battery of immunohistochemistry that we can use in Spitz tumors, and you'll all be familiar with these ones. I've included BAP1 largely because in the literature, BAP-POMA is included often in publications on Spitz tumors, even though it doesn't really belong there at all. And I've also mentioned MAP kinase immunohistochemistry, which I'll get back to. And this is a lovely example of a Spitz nevus showing preservation of P16 as you would expect in a Spitz nevus. And this is a lovely picture. This is in the old days I used to use S100 very frequently because it outlines the cell nest size, and so you can see the nest getting smaller as you go down towards the bottom, and it shows you the single cells, and it's often easier to appreciate with S100. And this is another case where I'm going to show you some immunohistochemistry. This is just a regular Spitz nevus. You can see that on low power magnification. It doesn't really show any features of concern. There's the top of the lesion. Just to remind you, you can get transepidermal elimination of nests in Spitz nevi, and it doesn't mean anything. But there's the top, and there's the bottom, and you can see there's clear maturation with depth. So on H&E, it's a Spitz nevus. But Antonina kindly did the immunohistochemistry, and there's P16 at low power examination, and there's P16 at high power magnification, showing that it's present from the top to the bottom, which is what we expect to see in a benign lesion. HMB45 is not expressed by the nevus at all, and Ki67, there are 1 or 2 nuclei, but that's the height of it. Now, we've progressed enormously over the last couple of decades with a much better understanding of the molecular basis of Spitz nevus and other Spitz tumors. And all Spitz lesions are characterized by MAP kinase activating mutations in about 50% of cases. 40% of cases the mutations are unknown, and the rest are a mixture of this, that, and the other. But very often with the Spitz nevus, if you look for a particular MAP kinase mutations, you will pick up perhaps BRAF, perhaps MAPP3K8, and then the receptor tyrosine kinase, including ALK, ROS, RET, and so on. And I'll show you examples of all of these as we go along. And this is this slide. I put this in just really to show you how beautiful Antonina's ALK is. That this is ALK1 expression, and it's very pretty, and it shows the typical growth pattern. Serine threonine kinases account to 5% of Spitz nevi, and of the receptor kinase fusions, ROS, ALK, and NTRK1 account for the most frequently encountered variants. So I'm going to spend a little time looking at some of these receptor tyrosine kinase tumors, and this is typical ALK rearrange Spitz. Well, it's Spitzoid tumor, but actually this could easily just be a Spitz nevus. It's important to remember that you may see this in the Spitz nevus, you will see it in the atypical Spitz nevus, and you will see it in Spitz melanoma. So it's not giving you an idea of the biological behavior. And alcomas may be seen in a wide age range, and they typically present as dome-shaped nodules on an extremity, and they're composed of fusiform nests which extend from the top, gradually getting smaller as you go down towards the base of the lesion, and they typically show this plexiform growth pattern. Most algae-arranged spitzoid tumors look pretty bland, but occasionally they can be pleomorphic. And a significant number will show sentinel node involvement, which is not going to tell you anything. And in fact, I think sentinel node lymph node biopsy is not really a great idea for Spitz lesions. And this is the alcoma that Antonina shared with me. And you can see the fascicular growth pattern. You can see maturation with depth in the middle. And if you look a bit closer, you can see some junctional activity at the top. And there's, in that intermediate magnification, you can see the nest size is getting smaller, and at the base of the lesion you can see single cells. So everything on that histology says it's benign. But, you should expect to see mitoses in Spitz nevi, particularly in young patients. And so finding a mitosis or two doesn't necessarily change the diagnosis. And obviously you may well see a little bit of pleomorphism, not very marked, but you expect to see it. And again, it doesn't change the diagnosis. And there's the alkin again in that tumor. NTRK1 Spitz tumor, this is something I haven't seen so many of, and this example was kindly shared with me by Mattheos Bobos from Thessaloniki in Greece, and they're described as showing a filigree-like ridges with elongation, thinning and branching. And I don't think that fits very well, but that's just an example that I do have. And they are spindled, and I think, to be honest with you, they're not that dissimilar from the alcoma. And there's another view there showing you the extent of the lesion. Here you can see the spindle cell population. And then if we look at the next one, you can see the spindle cells at the top, and there's the base of the lesion there. And you may well find mitoses. The alcoma and NTRK1 lesions remind me of the malignant Spitz nevus that Catherine Smith described in 1986. And there you see, there's a mitosis there, and I think there were several mitoses in the tumor, and this is NTRK1 expression. Now, ROS fusion, I included this case from Thomas Weisner's paper, and if you haven't read this, I'd recommend it all to you. It's a super paper. And really gets you up to speed on the receptor tyrosine kinase story in Spitz tumors. And ROS1 fusion lesions show typical Spitz morphology, as you see in this example. And here's another one that Professor Nima Ardakany from Australia shared with me. And again, it's a spindle cell Spitz. There's nothing very problematical about it. Now, where the trouble starts, to my mind, is when we got the atypical Spitz tumor introduced, because It's not that I think that every Spitz lesion can be categorized easily every time into nevus versus melanoma. I think that at least 95% of cases you can, but then you do have cases where there's a little bit of uncertainty, and I suppose this is where the atypical Spitz tumor comes in. But the problem is it doesn't have a precise definition. The Spitz nevus overlaps with the atypical Spitz tumor, and as you'll see, the atypical Spitz nevus overlaps with Spitz melanoma. So there are no strict definitions which enable you to say, this is Spitz, atypical Spitz, except perhaps at a molecular level and with immunohistochemistry. If you see a lot of Ki67 expression, that's reasonable good grounds to shove you into this category. And similarly, if you see 9p21 mutations, that's probably a good reason to go into this category. But as for the rest, it's very, very variable, and you know, you, for example, symmetry, Spitz nevus symmetrical, atypical Spitz may be symmetrical or it may be asymmetrical, and so on and so forth. Nothing's terribly clear. And this is a lesion that was diagnosed as an atypical Spitz tumor. And I can't tell you for definite what it is. Personally, I would have called it a Spitz melanoma. But it is a matter of opinion, I suppose. This is a big lesion. It's 9 millimeters, and it's ulcerated. So the size and the ulceration to me are telling me, gosh, this is melanoma. And when you look at this lesion, you can see that it's a really dense infiltrate that doesn't, the cell size doesn't seem to be diminishing with depth. Everything down here looks the same as everything up there. So I'm not very madly keen on maturation. But then when we look at it at higher power, you can see the top where it's got nice retraction artifact, discohesion, so it's very Spitz looking. And this field gives you a suggestion, maybe there's certainly diminution in nest size when you go towards the base, and it looks as if there may be some diminution in cell size. So maybe the higher power images favor that there is maturation. But then when we look at it at high power, this is the base of the lesion, and there's a mitosis right at virtually at the base. This is the middle of the lesion with a mitosis. There's another one in the middle of the lesion. There's another one in the middle of the lesion. So ulceration, very large, superficial and deep mitoses, mitosis almost at the base. And then we look at the immunohistochemistry. P16 is preserved. Ki67, well, I haven't estimated, but it's pretty strikingly positive. HMB45 is retained throughout. And PHH3, about which I have little experience, doesn't seem to be showing up very much. I think this is melanoma, but it was diagnosed as an atypical Spitz tumor. And I suppose at the end of the day, even a Spitz melanoma is unlikely to do the patient any great harm in the overwhelming majority of cases. So to some extent, it's a bit academic. And here's a case that Mattheos shared with me. It's a lovely case. This is an alcoma, and it shows a fairly large 0.7 centimeter diameter lesion, but it looks somewhat symmetrical and circumscribed, and there's the base of the lesion there. So at low power, it's suggesting benign, and at higher magnifications, it's still, to my mind, suggesting benign. It looks as if it's maturing. There's the discohesive population. There's the retraction artifact. There are the Camino bodies shown in higher power. So at the moment, you're thinking, great, this looks like a benign Spitz nevus. we looked at it a bit more closely. There's the base of the lesion. And here we see a mitotic figure there. And we're beginning to pick up something that's very concerning, extensive lymphovascular invasion. I don't really think I can call lymphovascular invasion a Spitz nevus. To my mind, I put this into the Spitz melanoma category. But then we look at P16, it's preserved. And here's ALK showing strong expression throughout. And there's the intravascular component there showing expression. This patient had a sentinel node biopsy, and there's quite extensive involvement both within the body of the lymph node and in the subcapsular region. So I'd be inclined to regard that as a Spitz melanoma. And there's Mark 1 with key 67. And then we get to Spitz and Spitzoid melanoma. Now, in a moment, I'll discuss the difference between these two. And I'm not going to spend time on this. It's in the books. You can all read it for yourselves. The only thing I would say is that here the molecular studies can be very useful because they can push you towards melanoma much, to my mind, in a much more confident sense than with the histology. Except, and again, immunohistochemistry, key 67 is very useful. If there's a lot of key 67, greater than 20%, well then you better start getting worried. I rather like this is the sort of diagnosis that I like to come up with. A Spitz or Spitzoid melanoma is a melanoma that you called a Spitz and wish you hadn't because it metastasized and there were terrible consequences for the patient. And it can be divided on histology into a melanoma which shows vague Spitzoid features but is clearly malignant, or it can be a Spitzoid lesion with additional features that suggest melanoma, but it still looks more like a Spitz nevus. And I got this image here from Antonina showing you a Spitz melanoma with, there were 17 mitoses in that one section. Now, we do need a reality check. Melanoma in children, and this is from the 2017 article, melanoma in children, 1.1 per million in the 1 to 4 year old age group, and 10.4 per million in the 15 to 19 year age group. So it's extremely rare, and that's I couldn't stress that more strongly. It's an extremely rare tumor in children. And those that do occur, some of these will represent melanoma arising in a giant congenital nevus in patients with, say, xeroderma pigmentosum or some other inherited predisposition syndrome. And some of them will be actually will be misdiagnosed proliferative nodules. And here we're going to get to the good, the bad, and the ugly that I mentioned in my starting slide. And this is summarized from a wonderful paper by Raghavan et al. And most of the melanoma authorities were co-authors on this paper. And if you haven't read this one, you jolly well ought to. And basically, the thesis of the paper is that you can divide malignant Spitz lesions into 3 categories. The first one is the good lesion. It's a Spitz melanoma with MAP kinase activating mutations, but low promoter mutations, few pathogenetic mutations. So this is a lesion that looks like a Spitz nevus Its immunohistochemistry looks like a Spitz nevus, but it histologically shows features that you can't avoid, and so it becomes a Spitz melanoma. And then the second category, these are the bad lesions, and these are spitzoid melanomas with non-spitzoid MAP kinase activating mutations. So it's the exact opposite of type 1, and these tend to occur in older patients with high cumulative sun damage and lots of somatic mutations, and the prognosis is bad. And then we have the third category, the ugly category, and these are tumors which look histologically ugly, but they don't show MAP kinase mutations. They occur in younger people. Again, they have low TERT promoter mutations and few pathogenic mutations. So in an ideal world where you have all the molecular technology to hand, you can perform all of these studies and you can classify the malignant Spitz lesion into type 1, the good, type 2, the bad, or type 3, the ugly. And I'll show you a few. And this is a case that Ari very kindly shared with me. This is an NTRK1 Spitz melanoma, and on the right with the histology you can see, you sort of get the sense that there may be some maturation but death, but still the bottom of the lesion, the nests are pretty big, and it's clearly ulcerated along an extensive part, so it's not starting off very well. And when we look at it at higher magnification, there's the top of the lesion with the ulceration. This is the bottom, and here we're coming down to the bottom, and there's a mitosis there. So there's a mitosis right deep down, and there is some nuclear pleomorphism, more so than you'd really want to see in a Spitz nevus. And when we look closely, there are multiple mitoses, including atypical forms. There's 1, there's 2, there's 3, and there's a 4th one there I forgot to arrow. So that's one high power field with 4 mitotic figures and significant nuclear pleomorphism, enough to call this a melanoma. And this is Antonina's patient, and this child developed lymph node metastases sometime after the diagnosis of Spitz melanoma was made. And again, it's an ulcerated lesion. And at the top we can see some residual junctional nests. And there's the surface epithelium there, and here we can see 3 of those mitoses as one works one's way down the tumor. And there's the base of the lesion, you see, and there are large nests coming down towards, there's a large nest there. So although you might think, oh, it's splitting up into cells at the base, that's really a sort of a false impression, because there are 2 big nests there, so it's not really maturing. And there are all the mitoses, and there's a close-up view just showing you the mitoses to better advantage. And this is P16, which was entirely lost throughout the tumor. So that was a P16 or 9P21 homozygous deletion that resulted in lymph node metastases. I don't have any follow-up information. And then we've got this case, which is another 9P21 homozygous deletion, very kindly shared by Jonhan Ho from the University of Pittsburgh. And this is the low power view. And again, when you look at the middle of it, you sort of get the feeling that it looks as if it is maturing. The cell nests and cell size, you might think they're getting smaller. But here we are, this is sort of the middle of the lesion, and I would caution you, when you're looking at a spitzoid lesion and you get nests like these are expansile nests, and they're pressing against each other. Always view that with great concern. I really don't like expansile nests. And there's some other views, and they're showing you the junctional activity at the top. And there's a medium part of the top, and there's the bottom. And if you compare the top to the bottom cell size, you'll see there's no difference at all. It's not maturing in terms of cell size. And there are mitoses, superficial mitoses, another one there. There's a deep one, there's the deep margin there, and there's another one there. And here we see Menorah with key 67. Key 67 are the red nuclear dots, and they're pretty conspicuous once you get your eye in. So that's a Spitz melanoma. And this patient also had regional lymph node metastases. This is an example of Spitzoid melanoma that I picked up from Raghaven's series because I don't have the molecular data of one of my own. But again, it looks very Spitzoid, but the size of the cell nests alone are very disturbing. And there you can see loads of mitotic figures. So it would worry you, but this in fact did not have ALK or didn't have MAP kinase mutations, and so it fits into the bad category. And then lastly, this is a case that Wayne Grayson from Johannesburg shared with me, and I've forgotten the size. It was 7 or 8 centimeters or millimeters in diameter. At low power, it looks as if it's maturing, but the thing you can see here is it's not symmetrical. If you compare the population on the right with that on the left, they're totally different. This is a sort of a spindly population maturing. Here we've got this focus of epithelioid cells which are not maturing, so that makes you sit up and think. And there we have a closer view. Compare the left and the right, and it's asymmetrical. And this is coming down towards the base of the lesion, and you can see there's no maturation towards the base. And here are some mitotic figures. This lesion was teeming with them, but I highlighted 4 for you. And the tumor also showed lymphovascular invasion, very extensive. And so again, one was left with no doubt in my mind that this was melanoma. And this is the S100 protein, and it's quite good because it highlights the difference between the 2 cell populations. And this is HMB45 showing that there's no loss of HMB45 expression with depth. And this one just shows CD31 highlighting the intravascular component, and their cyclin D1 indicating expression throughout the entire depth of the lesion. So I hope this talk has given you some thought. It's given you some references that you really need to read, and I want to remind you, really, that don't be frightened with Spitz nevi. Most Spitz nevi, that's all they are, and don't focus at high power on one particular feature. And let's say you find a deep mitosis. Don't let that lead you off the garden path. It's the aggregator features that will give you a diagnosis. And in difficult cases, immunohistochemistry, molecular studies, and don't forget to show the slide to a colleague or send it off for consultation. And lastly, don't shove everything into atypical Spitz nevus just because you can't make up your mind. It doesn't do the patient any good. So thank you very much for your time, and that's all I have to say.